Awesome. Good afternoon, everyone. We have a bunch of folks logging in as we speak. So we're going to go ahead and get started with some housekeeping items while everyone joins to get us ready to go. Today is Wednesday, December 7th here, and we are in the 4th of 6 scheduled sessions on managing pediatric patients with acute respiratory illness. Today's session focuses on pediatric intubation. A few housekeeping items. This webinar is being recorded, and the recording will be posted to the RDHRS website. To limit background noise and with the large number of attendees, your microphone has been muted for the duration of the webinar. We encourage your questions and comments. If you have a question or comment at any point during the webinar, you can type your question into the Q&A box. We'll do our best to answer your questions in the box or during our audience Q&A session. At the end of the webinar, we will be sharing a link to a short survey to gather your feedback. The information in the survey helps us to develop future sessions and identify topics for other webinars. We really appreciate you taking the time to complete that. So if we go ahead to the next slide, I'd like to introduce myself. My name is Eileen Searle. I'm the Executive Director of the Regional Disaster Health Response System Program located at Massachusetts General Hospital. I'm also the Director of Funded Projects in the Center for Disaster Medicine there. The RDHRS is an initiative supported by Health and Human Services Administration for Strategic Preparedness and Response to address healthcare preparedness challenges, expand access to specialty care, and support optimal patient care during disasters or urgent public health circumstances. As we are all aware, the New England region, as well as much of the country, is continuing to experience an unprecedented number of cases of acute infectious respiratory illness in children and infants. The Region 1 RDHRS is providing access to resources and tools to assist hospitals, clinicians, emergency managers, and other health professionals in response to the pediatric surge. One of our key resources is the launch of this educational series on providing care for pediatric patients with acute respiratory illness. These sessions are interdisciplinary to provide clinical teams from nursing, providers, and respiratory therapy disciplines with information and resources to support their care of pediatric patients. Today's session is the 4th of 6 weeks of content that we have partnered with clinicians from across New England to develop and host. Our goal of this educational series is to provide support and information that will benefit clinicians at the point of care. We're really excited today to be joined by a strong and robust team from Connecticut Children's Medical Center. We're joined by Dr. Allison Cowell, who is the Medical Director of the Pediatric Intensive Care Unit and the Medical Director of Respiratory Care. We're also joined today by Megan Yanaros, who is a registered nurse and a critical care registered nurse. She serves as the clinical nurse educator in the Pediatric Intensive Care Unit. And we will also be joined by Chris Goodell, who is the clinical educator of respiratory care at CCMC. So with that, if we go to the next slide, please, we'd like to acknowledge our funding from ASPR, and at the present time, none of our participants have any disclosures for this presentation. With that, I'd like to welcome Dr. Cowell, Megan, and Chris as he's able to step away from the bedside and join us. Allison, it's all yours. Oh, you're on mute, Allison.
There we go. Hi, everyone. Thank you so much for joining us. We are here to help present information about pediatric intubation. Our objectives today are to discuss why one would intubate a child, how children are different from your adult patients, what you should know before you intubate, what do you do to set up, what medications will you give, and how do you actually perform the intubation itself. So to just start out, why are you going to intubate a patient? So these are the same reasons that you would intubate an adult for hypoxic respiratory failure, hypercarbic respiratory failure, shock, and CNS dysfunction. But most importantly, in this acute viral season, we ask that you think about it if the patient has failed less invasive methods. Believe it or not, children are really quite resilient, and so they can look pretty bad because they have very little chest wall musculature and abdominal musculature, but they can do very well with non-invasive medicine methods. And so they can tolerate not being intubated for a lot longer than a lot of adults. Apnea in young infants can sometimes be treated just merely with the noxious stimulus of a high flow nasal cannula or CPAP prongs, as a lot of these viral illnesses have the effect of targeting the respiratory center within the brain. And so it really is that the kid actually forgets to breathe. And if you make them a little bit uncomfortable, they remember. So they can get away without having a breathing tube in place. Signs and symptoms of respiratory distress in an infant or a toddler are pretty much the same as in an adult, though they have a tendency to do some of these grunting, head bobbing, nasal flaring pieces that adults you don't see as much. Children who can talk to you usually are not having enough respiratory distress or failure to be needing intubation. Similarly, children who cry with a robust cry also generally do not need to be intubated, but children who are unable to do all those things and who are grunting and almost auto peeping like you would see in an adult are much more concerning and generally need to move along towards some sort of extra support. That support can be non-invasive or invasive. So how are children different? Children are not little adults. That's the mantra of pediatrics all over the place. But when it comes to that, what does make our patients different is that their anatomy is different. And that will, because of the larger head that comes with just being a child in comparison to the body. As a result of that, you end up with airway positioning issues, a larger tongue that gets in the way of being able to see the airway, angled vocal cords. Their epiglottis is a different shape, and the larynx and the trachea itself also are different. So moving forward, if you look at this picture of an infant versus an adult, you can see that the head and the occiput are much larger on a child than they are on an adult, which as a result ends up making the angle from the mouth to the pharynx, through the pharynx into the trachea at a very different angle than that of an adult. Also, the tongue sits deeper and in a more curled fashion. It generally is larger in comparison to the size of the rest of the oropharynx, so it needs to be moved out of the way. If you look at these images, if you put a patient in neutral position, you can see that there's these angles that are very difficult to traverse when you're trying to stick in a straight endotracheal tube. If you extend the patient who has a slightly larger occiput, you have a much more straight line to be able to do that. So how do you do that? We hit something called the sniffing position. So if you look at this, depending on the size of the child, you have to put them in a different position. So our younger children, but who are toddlers, do very well with just having a pad put under their head. That will allow for this lining up of the oropharynx and the trachea. And if you hyperextend the neck similarly at the same time, you get an even better confluence of all of the angles so that you have one place to look and it is a straight shot. With our neonatal patients or infants, because their occiput is so large, we end up needing to put the roll instead of under the head, under the shoulders, so that you can actually lift the shoulders up off the bed and get that better angle. And if you lift the shoulders themselves, you see that you fix two of the angles, but as soon as you pull the head back into the sniffing position with the shoulder roll, you end up with a straight line and a straight shot for being able to stick the endotracheal tube in. A poor man's way of looking at it is this ear to thoracic notch angle that you can see kind of from the side of a patient. and try to make it so that the ear of the child and their thoracic notch are in the same plane. And then that generally makes it a little bit easier for you to be able to put the breathing tube in. So this also shows that the tongue is larger and that the vocal cords are angled. And this is a great example of the omega-shaped vocal cord, epiglottis, excuse me, that happens with pediatrics, as opposed to this, your larger adult epiglottis that is just a nice arch. In this newborn, you have to be able to lift up that omega shape and realize that these two sides are probably going to fall in if you don't lift it high enough. And through this little hole here is where you're going to find your vocal cords. So you can see on the adult view, you have the epiglottis and you can already see the vocal cords. And I would tell you that this view of a newborn is actually probably what I would consider a grade 1 view of the vocal cords, but that's because I know that they happen to be stuffed right in there. The other thing that is anatomically different with pediatrics than adults is that the narrowest portion of the airway in a pediatric patient is the subglottis. In an adult, the narrowest portion is the vocal cords generally. So if you see here, you have this narrowing and the funneling of what happens once you get below the cricoid. And so when we put up a balloon, and we will talk about cuffed versus uncuffed endotracheal tubes, you have to be cognizant of the fact that the cuff is going to sit in the subglottis, so it's going to hit this smaller area, but that there's going to be lots of room around the vocal cords themselves.
Yeah.
Not all children are born anatomically normal, and each of these individual syndromes can cause an extra challenge in being able to put a breathing tube in place. So the ones that we frequently see that are more challenging are these Pierre-Robin and Treacher-Collins, where the child is so retrognathic that it is difficult to be able to find the anterior vocal cords in that patient. The other thing is that Down syndrome kids with trisomy 21 often have some atlantoaxial instability. So you have to be careful when you put them in a sniffing position or too far of a hyperextension that you don't impact spinal cord perfusion. Many of these other things are much more rare, but they do provide some difficulty with placing endotracheal tubes. The other thing I will tell you is when we talk about buck teeth or missing teeth, remember that children, it's normal for them not to have teeth. So you be aware, just as you are with adults, that you have to watch the teeth. But in this case, especially in infants, if you push your blade, your laryngoscope blade into the child, you will end up causing buccal hemorrhage or gum hemorrhage, as opposed to dislodgement of teeth, because you're going to hit actually the native baby mouth that never had teeth to start out with. So when we talk about equipment or supplies, this is, I will tell you that endotracheal intubation is truly a multidisciplinary approach, a multidisciplinary task that has a multidisciplinary approach. So I'm going to stop talking and allow some of my other colleagues to jump in at this point and talk to us about what all they bring to the bedside as well.
Sure. So anytime that we're preparing to intubate a pediatric patient, our nurses will do sort of a quick safety check of the room and see, do I have everything I need? So primary things that includes are going to be a resuscitation bag. So we typically use a flow inflating bag here. There are ambu bags that are used elsewhere. We want to make sure that we have one of those and it's the appropriate size, an appropriate size mask for the patient. We also want to make sure that we have oral suction and a separate suction available for our endotracheal tube after the tube is actually in. We use inline and tidal CO2 devices to confirm placement. So we will have one of those set up as well, but there are also easy caps that we have in our code cart. And we have a portable CO2 detector called the Emma, which we use as well for confirmation of placement. We want to take a look around the room and make sure that it's set up appropriately as well. So our nurses will pull the bed out so that there's space behind that for the physician to get in and actually do the intubation. And we try and remove extra clutter, extra chairs, things like that from the room so that enough people can get in there. We also want to make sure that the RT got a chance to set up the ventilator, so that's going to be ready when we need it, and that we have all the appropriate people. So our team typically includes at least one physician who's going to be doing the intubation, typically another physician who will be helping ordering things like that. We need at least one RT. There's usually two nurses, usually one to draw medications and one to actually give the medications. Another person available to pull supplies from the chemical box where we keep all of our supplies, or from the cart if that's what and then Chris, I don't know if you have anything to add.
Yeah, sorry, there's a fire alarm going off right now, so there's a lot of background noise. So, yeah, Megan, you touched on all the great stuff. Usually, the big thing is just a higher FiO2 oxygen device, like a high flow nasal cannula, turning that to 100%. Or if your facility has non-rebreathers or so forth, just giving the patient as much O's if it's permissible. And then also from an RT perspective, suction and so forth, and just having the ventilator ready for once you are done intubating.
Allison, you can come off mute. We had to mute you for a minute there.
Sorry. Yes, I'm in an office that has other noise behind me. So many of you may be familiar with this Breslau tape. It comes with pediatric code cards, and it's a nice tape that you can lay along the side of the patient to give you a sense of what size bag you should be using in mask and airway and laryngoscope and endotracheal tube, and it's color coded. So we will go into what happens if you do not have one of those, but these are this is a nice, easy cheat sheet, if you will. So when intubating, there's the difference between the Miller and the Mac blade. Mac blades you may be very familiar with using in the adult world. They're great at being able to pick up the vallecula, and then you can slide the tube underneath. The Miller blade is a straight blade, and it is great in a pediatric setting because it allows you to pick up that floppy epiglottis and move everything out of the way. So remember, when you go into the vallecula, you're just going to be able to see the epiglottis and get everything else out of the way and have to go underneath it. And if you can't see the vocal cords, that's a little bit more of a challenge. We use the Miller most often because of its thinner, straighter sense. The anesthesiologists sometimes have more fancy things, but I will tell you, you can intubate any patient with a Miller, regardless of the size of the patient. Even if they're a large, almost adult sized patient, you can always use a Miller blade. The Mac blade is wider and more curved, and they do come in very small sizes, but they take up too much real estate within the mouth. And so it becomes very difficult to actually be able to find where you're going because the curved blade itself just takes up a lot of room in a very little mouth. What sizes do we use? So Miller 1s for children less than 1 year of age. Some people use Miller 0s in the absolute neonatal period, like in the delivery room. But Miller 1 will be fine. Miller 2 for most children who are in the toddler age group. And then you can go to Miller 3s or to Mac 2s for those who are older. The Mac 2 says that it can be used in the 1 to 10 year age group, but I will tell you, it was really difficult to use in anyone who's under the age of 5. Mac 3 is the same as, a larger Mac that you would use in an adult. And you can decide based on the size of the child. Some 18-year-olds are very large, and some 18-year-olds are the size of a 5-year-old. And so you do based on anatomy, not based on chronology and age. So to put in the cuffed or an uncuffed. The old teaching was to use an uncuffed endotracheal tube for anyone under the age of 8 because we did not want to create subglottic stenosis. As I explained before, that the subglottis is the narrowest portion of the pediatric airway. However, after multiple studies, it was proven that those children who were intubated with a cuffed endotracheal tube had no more post-extubation stridor than those who were intubated with a uncuffed. And the cuffed endotracheal tube allows us much more flexibility with oxygenation and ventilation and is much better for the patient who has severe lung disease. So we would recommend and advocate for a cuffed endotracheal tube in every single patient. So figuring out the size, this is a nice chart to help you look at what size endotracheal tube and what size suction catheter. But we use often, if I don't have a chart, I use a calculation. So for the cuffed endotracheal tube, it's 3 plus the H divided by 4 or 16 plus the H divided by 4. You can do it with the uncuffed at 4 plus the H divided by 4, but that might give you a slightly larger endotracheal tube. And then the endotracheal tube depth is 3 times the caliber of the ET tube. So if you're putting a 4.0 ET tube into a patient, you should plan on initially sticking in it at 12 centimeters. Chris?
So ventilating with a bag valve mask. So prior to even starting your intubation, you're going to want to check that the device that you're using to bag a patient works correctly. That would be for checking for any leaks or cracks in the device that you have. Also, a lot of the bag valve masks require a PEEP valve if you do need to administer additional PEEP above just what the bag gives. And also checking to make sure that if the bag does have a pop-off valve, a lot of them are manufactured so you can override or ensure that it's closed. And they usually pop off around 40 centimeters of water pressure. But sometimes you may need to ventilate above those pressures for some patients. So it is a nice thing to check for. Also, just checking and making sure that your O2 tubing is attached to a flow meter and is on, and listening for the flow in your reservoir device of your bag valve mask. And also just ensuring that you have an appropriately sized mask for a patient and that the cuff around the mask is still full of air, or some of them you can add air with a syringe. Just making sure that it's full of air, that way it makes a nice tight seal around the nose and mouth. And also you just want to ensure the ability to ventilate and bag valve mask a patient, because going into an intubation scenario, it's better and you're more rest assured if you're able to bag the patient, because it may take several attempts to intubate a patient. And Allison spoke about this before, but for kids under 2, they may need that shoulder roll under the towel roll under their shoulders to line everything up and get that correct sniffing position. Whereas older patients, the head tilt, chin lift often aligns all those axes so that the person intubating can view the vocal cords. Also, having an end-tidal CO2 device in line while you're bagging sometimes helps, because then it can ensure that you're actually ventilating the patient. So preparation is always key for successful intubation. So you're going to want to make sure that you gather all your supplies prior to the procedure. I know in our PICU, we have an intubation bag, which essentially has all the things that we need. And you're going to want to ensure the function of the supplies prior to intubation, like your Miller or your Mac laryngoscope, making sure that the light is functional and so forth. Your bag is there with the appropriate mask, your ability to ventilate the patient, and also ensuring that you have proper suction and the suction pressures as well, and testing those beforehand. And then team member communication just during the procedure. Like Allison said, it's a multidisciplinary task. There's many people in the room, but the MD or whoever is intubating, and everybody, whether it's the nurse giving the drugs or the RT assisting, having closed loop communication. This is vital when we're giving meds for intubation and also during the actual procedure. I know a lot of times that I've been in intubations, it's always nice to do this closed loop communication, especially when I'm providing cricoid pressure or the doctor's telling me more, less, and so forth, so they can get that perfect view of the vocal cords. Also, your ability to bag valve mask a patient as an RT, if you're unable to do it and you're having difficulties speaking up and getting an extra set of hands in there is also helpful. And also vital signs monitoring, just having maybe another nurse in there looking at the monitor, because oftentimes the doctor, the RT are basically at the head of the bed and the monitor is behind us. So having someone there letting us know sats are low and so forth is helpful. That way we know maybe we need to remove the laryngoscope and start bagging and wait for another turn.
So from a medication perspective, the medications are often very similar to the ones that you use in adult medicine, except for we just use weight-based dosing. The one I want to highlight is the use of atropine. So it used to be taught that atropine was to be used in every infant intubation so that you avoided bradycardia, as bradycardia is usually the sign of cardiovascular failure in children. However, with many studies, there was not really any good data to say that atropine actually blunted the vagal response enough to prevent symptomatic bradycardia. So most people now don't necessarily give it, but there isn't anything wrong with giving it. I just want to remind you that if you're using, if you are intubating a patient for neurovascular issues or for a TBI, atropine will dilate the pupils for an extended period of time, and so you will lose your pupillary examination. Some people prefer to use glycopyrrolate, especially if intubating with ketamine. It's a way of drying out the secretions, and it can actually work in the same way as atropine, not just blunting the vagal response and preventing bradycardia, but can actually give you a slight increase in heart rate. Remember, pediatric patients, unless they have congenital heart disease, tolerate increased heart rates very easily and very well for a prolonged period of time, as opposed to we the grown-ups. So of the medicines to use to intubate, etomidate has become the go-to for most people in the emergency department, the same as in adults. It works exactly the same way as it does in the adult physiology. The one difference that I've noticed is that everybody knows that it can cause adrenal suppression, and we're taught that in the books, but in patients who are septic in pediatrics, if you're having difficulty with fluid refractory shock, or you're having to start some inotropes, but you have used etomidate, think very highly about giving 1 dose of hydrocortisone to overcome the etomidate that you have given. As you know, it works in 15 to 30 seconds, and the dose of etomidate is 0.3 per kilo. Propofol is also a nice medication to be able to use that works in 30 to 60 seconds. It is pre-mixed, so you don't have to dilute it. It comes in the exact same way for adults and pediatrics, but it does lower your blood pressure significantly. And pediatric shock usually presents without hypotension. So if you get to the point of having hypotension, be concerned about cardiovascular disease or difficulty with significant amount of shock, and be cautious in using propofol. Ketamine is another great drug, and the benefit of ketamine is the biggest benefit from my perspective is that it can be given IM. So in a lot of these little babies, it's very difficult to get peripheral IVs, and so if you are looking at a baby with extremis who you can't get an IV, you can give them a nice dose of ketamine IM, and it will work just fine. Normally, ketamine works in 1 to 2 minutes. If you give it IM, I would expect 2 to 3 minutes, but it works the same way as in adults. The dose for this is 1 to 2 milligrams per kilo, and oftentimes we titrate to nystagmus. And then the gold standard for the long-term sedation has been and always will be fentanyl and Versed. It's a nice opiate benzo combination. You don't get prolonged delirium from 1 dose of Versed for use for intubation, so you don't have to worry about that with your benzodiazepine. The nice thing about these medications is that they work synergistically and they last for a long time. So when they say they last for a long time, they can last for 30 minutes to an hour and a half, sometimes up to 2 hours, depending on the metabolism of the child. So if you're intubating and you're sure you're going to get the tube in, then you can give them these medications and then not worry about them having, let's say, the etomidate wear off in 10 minutes, and now the child's trying to pull out their own endotracheal tube. The caution with this is you should be pretty confident you're going to be able to put the endotracheal tube in place, because now you're going to have a very sedated patient for a prolonged period of time. Muscle relaxants are almost universally needed and used in pediatric intubation. Vecuronium is a great drug to use. The dose is 0.1 milligrams per kilogram, and it starts to work in about 1.5 to 2 minutes time, and it lasts up to an hour. It does stay around in renal failure patients, but that is not a contraindication for using it. It's a contraindication for redosing it, but there's no reason to not use it for actual intubation. Rocuronium is a nice depolarizing agent, and the dose for that is 1 mg per kg, and it lasts for about 20 to 40 minutes. Chris?
So verifying tube placement. So it's the same as with adults as with children. You're going to want to use an end-tidal CO2 device. That's like the gold standard. Most places either use a side stream or an infrared end-tidal CO2 monitoring device. The one pictured here is a handheld one that uses infrared, which you can take. It's portable. A lot of monitors in hospitals have the capability for side stream and tidal CO2, but also once the tube is placed, you're going to make sure you have equal and bilateral chest rise and equal and bilateral breath sounds. With our smaller kids, this is very important just because just the length of the tube and the insertion, you have a smaller margin for error. Moving in like a centimeter or two, you can main stem a patient, and then that's not good at all. So just making sure you have equal and bilateral breath sounds. Chest X-ray also afterwards, and then condensation in the tube is always something to look for. Next slide. And then suction should only be performed when clinically indicated. Avoid saline lavages. Closed suction technique is pretty much the gold standard with an intubated patient. Is the preferred method. Pre-oxygenate as needed. Most ventilators have a pre-oxygenating setting for it. It keeps the system closed and clean from outside germs. And we don't use the same line for oral suction, so we have two different suction setups. The suction catheter stays in line for up to 7 days, and then it's discarded with a new one, unless it's soiled beforehand. We always anchor the tube while we're suctioning to make sure that the tube doesn't move and we cause accidental extubation. We go just past the end of the endotracheal tube based on the tube measurements on the side, and a lot of our suction catheters are color coded. That way we know which number is which on our suction catheters. Suction should only be applied on the way out and not while going in. It should last about 3 to 5 seconds. The open suctioning technique, it's a sterile technique. It's usually a 2-person procedure, one to actually hold the tube and disconnect the patient from the ventilator or the bag and to pre-oxygenate, and the other caregiver to actually suction the patient.
There are many different ways to secure a tube. The biggest thing to remember is that you will likely not be able to use the Hollister devices that adult hospitals are often used to. So there are many different ways. One of ours kind of looks like this little guy. I would just suggest that your institutions find a way that you like, standardize that and teach it. Simulation on a mannequin like this baby is a great way to learn that. Children, especially babies, are at a high risk for unplanned extubation. So now that you've worked so hard to get that tube in, you want to make sure that it is going to stay there. So finding a way to tape securely is really important. As Chris mentioned, that margin of 1 centimeter that you may have on a child with play in the tube could be the difference between keeping them intubated and extubating them. They're also at risk because they are smaller, flexible tubes, and these children may have more secretion. So they may have a lot of drool and saturate the tape. It may need to be retaped frequently to keep it secure. It's important to remember that these little babies, you look at them and you think that they don't look very strong, but they really can be. They may get their hand caught in the tubing or thrash their head and cause their tube to come out. So really keeping them nice and tightly swaddled for when they do wake out of that sedation is important. And really continuing to maintain an adequate level of sedation for their tube safety thereon.
So initial vent settings for after a patient is intubated for pediatric patients. I know in our institution, and if your ventilators are capable for the patient side, a volume targeted ventilation is preferred. We'll go into detail later, but a volume targeted ventilation does guarantee an actual minute ventilation for your patient as opposed to like a pressure control mode. Tidal volumes, we like to target anywhere between 6 to 8 mLs per kilogram of the actual body weight of the patient. And the body weight of pediatric patients is kind of like a poor man's way of determining their height. It's something that we use, but at the same time, you do have to look at your patient because if their BMI is high or low, you could under or overshoot your tidal volumes, which inadvertently under and overshoots your minute ventilation. If you are using pressure control, you can start with a pressure control anywhere between 10 to 15 above your PEEP. Just remember to look at your tidal volumes and your minute ventilation too, so that you are adequately ventilating your patient. PEEP usually anywhere from 5 to 8. As we'll get into in the other slides, if it's a hypoxemic respiratory failure, you may have to go higher on your PEEPs. And then respiratory rate, depending on how old your patient is, any respiratory rates may be as high as 30, especially because your patient post intubation will be paralyzed and cannot breathe on their own. So we have to do all of the minute ventilation for them. And then your I times, infants are usually 0.5 to 0.8 seconds, whereas you get to kids who are in their adolescent and teenagers, they're more like adults, so it can be like 0.8 to 1.2 seconds. And your pressure support, once again, this is a pressure delivered breath. So you want to look at your return tidal volumes, but anywhere between 5 and 10 centimeters above your PEEP.
So for hypoxemic respiratory failure, generally we suggest you start with an FiO2 on the ventilator of 50 to 100%. There's a lot of people who just stay at 100% in the beginning, and there's nothing wrong with that practice, especially after you've de-recruited a little bit with putting the breathing tube in. If you're starting persistently hypoxemic, I recommend starting your PEEP at 7 to 8. You can always wean down or wean up, but you're going to have to re-recruit some segments because you've just de-recruited in the process of putting the breathing tube in. You can wean the FiO2 relatively quickly. We generally don't go from 100 to 50 in one fell swoop, but you can go down by 5 to 10% every few minutes. If you cannot get below 40%, you can start thinking about going up on your PEEP by 1 to 2 centimeters of water. We use the PEEP FiO2 grid in ARDS the same way as the adults do. So there's nothing wrong with using an awful lot of PEEP, but just in the emergency department setting, I recommend trying to see if you can keep a PEEP of 10 or less. And a lot of that has to do with the fact that if you are not the point of definitive care and you're going to be transferring a patient, not every transport ventilator does a great job once you get to a PEEP above 10. So you're going to have to make sure that the patient can mesh with that ventilator. In hypercarbic respiratory failure, which is often what you see in bronchiolitis or asthma, you have different priorities. So in these cases, the end tidal CO2 becomes really important. You can use that with a nasal monitor through one of the nasal cannulas, or that can either deliver flow as well, that can monitor end tidal CO2, but you have to have the size that's small enough for little nares. So sometimes that can be difficult. So then, just as Chris mentioned, always place an end tidal in line for once you have placed the endotracheal tube in place. One thing that I wanted to add to what he said is that the Easy Cap is a wonderful color changing CO2 detector, but just remember that patients under 15 kilos have one size of an Easy Cap, and those above 15 kilos have another size of the Easy Cap. You would have to have both of them if you're intubating smaller kids. A lot of that has to do with the fact that the size of the tidal volume is smaller in the child who's under 15 kilos, and so the Easy Cap itself is more sensitive. When you think about hypercarbic respiratory failure, you're really trying to increase your minute ventilation as opposed to your oxygenation. And so you have to think about respiratory rates in comparison to what the normal respiratory rate is for the patient that you're intubating. So it is very common for infants to breathe 40 to 60 times a minute. That's normal for them. So to start on positive pressure ventilation with a respiratory rate of 30 breaths per minute may seem very large in comparison to an adult, but is absolutely normal in pediatrics and infant patients. You will decrease based on the age of the child. You can also increase it's in our patients who are infants who are very, very sick. We frequently have respiratory rates of up to 40 and 44. You just have to be able to make sure that the child can exhale before they start their next breath. So tidal volumes, as Chris said, either 5 to 7 or 6 to 8, depending on what your preference is. There's been a lot of literature written and no consensus updates. So pick a number somewhere in that vicinity. And just as in the ARDSNet documents from years ago in the adult world, 4 to 6 mLs per kilo is a fine tidal volume size when you're having significant lung disease. We try to do an open lung strategy of ventilation the same way as adults do. So we have to be cognizant of the fact that you don't want to have ventilator-induced lung injuries. So we use higher PEEPs and lower tidal volumes to be able to preserve the ventilation and oxygenation, but not create too much barotrauma from excessive peak inspiratory pressures. So, sorry, this is a duplicate. So when we set a minute ventilation, you can, if you're doing it in a pressure ventilation, make sure you think about what the pressure control or the delta P is above the PEEP. In general, we would like it to be 30 centimeters of water or less if possible, and you can get adequate ventilation with that. So if you think about your PEEP and you add your delta P, as long as it's around 15 to 20 centimeters of water, you're going to be below that threshold of 30 centimeters of water, and that in the majority of children will give you a tidal volume of around 7 mLs per kilo. That's if your lungs are with relatively expected compliance for someone with bronchiolitis, not normal compliance. So patients who are asthmatic or have bronchiolitis have the equivalent, the pediatric equivalent of COPD. So it's much more difficult to get them to adequately exhale. So a lower rate and a higher tidal volume may end up being your best strategy. And if you end up having to go over that peak inspiratory pressure, that a threshold of 30 centimeters of water, that's okay, especially in the short term, because if that's what you need to do to be able to adequately oxygenate and ventilate, that's what you have to do. In general, we are pushing pHs now down to around 7.2, 7.25 as a target, and we don't really worry so much about the PCO2. It's not as important in pediatrics at all. So as long as you can keep the pH above 7.2, 7.25, then you consider that a win and accept ventilation settings, ventilator settings that may not be what you ideally would prefer.
So training and validation, just to be prepared for when you do have to intubate a pediatric patient. So the first thing is, from an RT perspective, having ventilators that are capable to ventilate a PD or neonatal patient. Either purchasing the vent circuits and so forth, and then training your staff as well. All ventilators have different cutoffs for their PD and neonatal circuits and the modes and the tidal volumes they give. If you're unsure of, you can always talk to your clinical rep for whoever supplies your ventilators. Like I said, all ventilators have different cutoffs and circuit sizes and so forth. So it's good to figure that out ahead of time. Then also, I feel as an educator, simulation is always a safe place to have hiccups, have mistakes and so forth, so that when the real time comes, you can be prepared. So developing simulations around pediatrics, I feel, is vital. Just making simulations for common pitfalls, like we've said, like accidentally right main stem intubation on a pediatric patient. Also incorporating into the simulation is also the equipment that you'll be using. Like, I know the simulation may run long, but maybe you have a patient who comes in and the RTs have to set the ventilator up, just running through that, because a lot of times that could be a common pitfall in like an outside lying hospital where they have one ventilator, limited staff, and they may not know it. And also adding ventilator management, like some of the scenarios that we have here, into the simulation, and giving ABGs and figuring out like what you need to do, which settings you need to adjust, and so forth. And then just sedation management as well post intubation, because you're going to want to obviously keep your patient sedated until help arrives, and so forth. And that's all I have.
Thank you so much for that, Chris. I think those points there at the end, as we kind of process the information and think about, you know, how to train and support staff who may be called upon to intubate pediatric patients. Those are all great things. So often we focus just on the placement of the tube, but then there's the everything that comes after. So training for that, planning for that is also really vital. I'd like to thank all three of you. We do have some questions that I'm going to walk us through. But for those of you in the audience, please do continue to submit your other questions while we have some time to go through them. I'm going to talk, we have a couple of questions just kind of about the intubation procedure itself. So the first one that came through was on cricoid pressure. Is it still a recommended procedure, and is that reflected in PALS?
So cricoid pressure is recommended if necessary. It's just like an adult RSI. If you need it, because it's an RSI, you do it. There's nothing wrong with doing it. In fact, sometimes if you don't have the adequate size shoulder roll, it can drop that larynx a little bit into more alignment so that it's easier to put the endotracheal tube in through the vocal cords. No one will say that you have to do it, and no one will say that you don't have to do it. It's whatever's going to make you the most successful.
Great, thanks for that. Another one that came up, and Megan, I saw you typed an answer to this, but so we can have it more broadly recorded, was a question on recommendations on the technique to estimate ET tube depth for placement.
Yeah, so we talked about the formula that you can use, so 3 times the tube size. So if you have a 4.0 tube, just estimating about 12, you'll still need to obviously listen, make sure you have bilateral breath sounds, and get a chest x-ray to make sure that you're not too deep or too high. All your kids are going to be slightly different sizes, but it's a good starting point.
Great, thanks. This one that I'm going to share is a little bit more of a comment, but I think it invites a little bit more conversation about keeping the tube secure post intubation. And one of our participants shared, you know, that applying a C-collar can be helpful, especially if we're looking at transporting a patient. Allison, to some of your points that these intubations and initial management of these patients may not be at the site of their definitive care, and ensuring we're prepping them for a successful transfer, including transport to another location. I didn't know if you had anything any of you wanted to add on ET tube securement, especially if someone's being transported.
So I think if you put a C-collar on, there's once again nothing wrong with that, as long as you tell the ultimate destination that the C-collar is on for tube as opposed to for C-spine precautions, because we don't want to leave a child in a C-collar and forcing an MRI to make sure that their C-spine is okay. It will stop the child from thrashing their head back and forth, but I would tell you, don't underestimate the power of the pediatric tongue, and that they can just use the tongue and pull that out. So it doesn't stop you from needing to sedate the patient, and it won't stop their little hands from finding their way up there. Especially they like to grab the suction tubing and yank on that a bit. So I think sedation, if you have an endotracheal tube in place and you have a chest x-ray that demonstrates that it's in the right place, and you have oxygenation and ventilation, then I think it is perfectly reasonable for transport to muscle relax these patients. If when you get, I would give a short acting muscle relaxant in the beginning, like rocuronium, to make sure that you can adequately take over the oxygenation and ventilation on your own and you're not reliant on them to be able to draw their own tidal volumes. But if you can do it all on your own and you want to have a safe transport, there's nothing wrong with muscle relaxing the kid.
We often do muscle relax these kids as well because some of these small babies, especially our broncholytics who are intubated, will have significant periods of bradycardia when they're agitated. They'll bear down on their tube, especially if it may be a little bit too deep, or with suctioning, and they can have pretty significant bradycardia. They're generally responsive to a boost in FiO2 up to 100%. But sedation does prevent some of those things from happening, which may make your transport a little bit easier.
Great, thank you for that. I will give an opportunity for additional questions to come in. Allison, if you wouldn't mind advancing to the last slide while we go through these. For those of you on the call, we do have a brief survey. You can scan the QR code below to complete it. What I'm seeing here currently are more comments, and I think speak to really the practical nature of the information you presented, which is, are you willing to make the slides available, particularly as handouts? We will, of course, post the recording, but I think a lot of the medication slides and some of the formulas seem to be very nice, quick references for folks. So I'm seeing head nods. So yes, we will, to answer those few questions, make the slides directly available for folks on the RDHRS website. My last question comes as we think about kind of bridging what we talked about last week. So we've been building a little bit across the series. We talked a lot about high flow nasal cannula in week 2. Last week in week 3, we talked about other non-invasive positive pressure ventilation strategies, CPAP, BiPAP, this week to intubation. You talked at the beginning, Allison, about kids lasting longer. Are there some key things people should be looking for if they're implementing BiPAP on when it's time to really say we're moving towards intubation of this child that we want to flag?
So I think if you ask 10 intensivists that question, you get 30 answers. So the quick thing is there's no one great pat answer. If the patient is persistently hypoxemic and despite 100% FiO2 and as much PEEP as you can deliver from a non-invasive support method, you cannot get a SAT above 88%. I think that's a sense that you probably need to have true PEEP delivered in an invasive method. I will tell you though that when you intubate that patient has so little reserve that it's got to be a quick intubation, so it becomes a much less pleasant intubation to do. There are people who like to try to intubate earlier, and I understand the preference to make sure that the patient is secure and safe. But in reality, in bronchiolitis, patients actually do better than any of us can do for them. And so if they can maintain on their own, keep themselves decently oxygenated, it doesn't have to be well oxygenated, but decently oxygenated and decently ventilated, then I would let them go. There used to be a sense in old units where people would swaddle up these tiny babies, stick them in the furthest ports of the unit and have no one go in and see them except for every 4 hours to see how they were doing, and not unwrap them because we didn't want to see how bad their work of breathing was. As long as their SATs were okay and they would open their eyes and look around at you, we called it a win. So that's great if you're in a pediatric intensive care unit. I understand that. And so not everybody has that luxury because we'll be able to respond quite quickly. However, I would say really give it an old college try to let the baby do it on their own. And once we intubate broncholytics, usually they remain intubated for about a week or longer because of the secretion management. Whereas if we have them extubated and allow them to cough on their own, they do a much, much better job and get out of the ICU much faster.
Awesome. Well, thank you for that. So with that, we are, I believe, at the end of our time today. So we'll give everyone a few minutes back to stretch. We appreciate, again, Alice and Megan and Chris, you joining us, at knowing, the very real work that everyone is doing at their home institutions, taking the time to prepare this and speak with us all today. And we have 2 more sessions scheduled for the next 2 Wednesdays on topics. Again, for those of you joining today, completing the survey gives us ideas for future sessions on topics that would be helpful. So thank you all very much and have a nice day.